All right, today we're jumping into a topic that's absolutely essential in traumatology, distal forearm fractures. Seriously, if you're going to be anywhere near a trauma bay, you are going to see this injury all the time. So let's really break it down.
So you might be asking, why all the focus on this one fracture? Well, it's pretty simple, really. This isn't some obscure, once-in-a-career kind of injury. No way. This is literally the most common fracture we see in clinical practice. Getting a handle on how to manage it? It's non-negotiable. Okay, here's how we're going to tackle this. First, a quick overview of the fracture itself. Then, we'll get into the mechanism and diagnosis. After that, we'll cover the key eponyms, the classic names for these fractures. And finally, we'll dig into the big decision, conservative versus operative management.
All right, Section 1, Fracture Overview. Let's start by making sure we're all on the same page about what this injury actually is.
So what exactly is a distal radius fracture? Well, it's a break right at the end of the radius. One of your two forearm bones? Your patients are going to come in saying they broke their wrist, but for us, we need to be more precise. We're talking about an injury to the metaphysis, that flared out, spongy part of the bone right before you get to the wrist joint. And that specific spot? It's super vulnerable because of how all the force from a fall gets channeled right through it.
Okay, moving on to Section 2, mechanism and diagnosis. So, how do these things happen, and more importantly, how do we spot them and work them up properly? The story you're going to hear over and over is the classic FOOSH, a fall onto an outstretched hand. It's textbook. And when you look at the wrist, you'll often see that unmistakable dinner fork or bayonet deformity. I mean, it's so classic, you can almost diagnose it from the doorway. Your first step is always going to be an x-ray, no question. But, and this is super important, if you have even the slightest suspicion that the fracture goes into the joint, you have to get a CT scan. You just can't see the articular surface well enough on an x-ray to plan surgery, and you don't want to miss that.
Okay, Section 3. Let's talk about the eponyms, the classic names for these fractures. Colles, Smith, these aren't just for exams. They're actually a super useful clinical shorthand. They tell you exactly which way the bone is displaced, and that's the key to knowing how you're going to fix it.
So let's break down the big ones. First up, the Colles fracture. This is the one you'll see most often. Here, the distal piece is displaced dorsally, or towards the back of the hand. The Smith fracture is the exact opposite, sometimes called a reverse Colles. The fragment goes volar, or towards the palm. Then you've got the Barton fractures. Now these are a whole different animal because they're intra-articular. They go right into the joint. They're shear fractures, and they can be either dorsal or palmar. Getting these patterns straight is absolutely the first step in figuring out your treatment.
All right, so you've diagnosed it, you've classified it, now what? We get to the big question. What's the plan? And really, the path forward splits into two main branches. We're either going conservative or we're going operative.
Let's dive into Section 4, Conservative Management. This is the non-operative path, and it's our go-to for fractures that are either stable, not really displaced, or ones we can reduce and are confident will stay put.
So the protocol here is pretty straightforward, but every step is crucial. First, you've got to reduce it. We do a closed reduction, usually under a hematoma block with some finger traps for traction. Step 2 is getting the wrist into a very specific position. We'll talk about that in a sec, to keep it reduced. Third, you slap on a plaster cast. And fourth, and you absolutely cannot skip this, you have to monitor them. We get regular x-rays because, trust me, these fractures love to displace secondarily, right inside the cast.
Okay, that specific position I mentioned, it's called the Cotton-Loder position, and getting this right is the secret sauce for conservative treatment. Think about a classic Colles fracture. The break happens from falling in extension, and the fragment goes dorsal. So to hold it in place, we do the exact opposite. We immobilize them in Palmar flexion with ulnar deviation and pronation. It's brilliant, really. You're using the tension from the ligaments and the intact bit of periosteum on the other side to basically hold your reduction for you. It's just elegant biomechanics at work.
So, if everything goes according to plan and the fracture stays put, how long are we talking? Well, the patient is looking at about 5 to 6 weeks in a cast. But what if things don't go to plan? What happens when it slips?
Well, that brings us right to Section 5, Operative Management. Because, going conservative isn't always the answer. So let's get into the reasons we take a patient to the OR and what we do when we get there.
So when are we booking a trip to the operating room? Well, there are a few big red flags. If you can't reduce it with your hands, it's called irreducible, you've got to operate. If it's just plain unstable from the get-go, you operate. If it displaces later in the cast, that's a huge one. You operate. And probably the most critical indication is any significant intra-articular displacement. We're talking a step off in the joint surface of more than a millimeter. If you leave that, you are basically guaranteeing that patient will get post-traumatic arthritis down the line. We have to fix that perfectly.
All right, so what's in our surgical toolbox? Well, the go-to for most of these nowadays is the volar locking plate, or LCP. This thing is amazing. It's a plate with locking screws that creates a super stable, fixed-angle construct, which means patients can start moving their wrist much earlier. For simpler fracture patterns, we might use percutaneous K-wires. We just drill a couple of pins across the fracture through the skin. It's less invasive. And then for the really nasty ones, severe open fractures with tons of soft tissue damage, we'll use an external fixator, which is basically like scaffolding on the outside to hold everything steady.
And this really brings us to the heart of the matter, the ultimate clinical judgment call. For every single patient that comes through the door with this injury, you've got to ask yourself this question. You have to look at the fracture pattern, consider the patient's age, their job, their hobbies, and decide, when is the risk of this thing slipping in a cast just too high to accept? Nailing that decision, getting it right for each individual, that's not just science, that's the real art of managing these fractures. And it's what makes all the difference for your patient's outcome.